the screen. We speak about procedure skill. Okay, so you can, okay, all right. Okay, so you see the screen now. So
Yes.
the first station, usually suturing of the wound, is the common station. And we have a scenario like this. 26 years old man have a cut wound in the thigh, in the right thigh. The nurse cleans the wound, give him analgesia, inject local anesthesia, and you will do 3 interrupted suture. Examiner ask you some question, give instruction to the patient after you will finish or during procedures. So this is easy station. Is suppose the patient have bad or some synthetic material in the thigh, so they have longitudinal cut wound. So what you do, you make suturing. Usually the examiner asks you first a question about what is the local anesthesia you're giving. So it is local anesthesia is lignocaine or xylocaine. The dose usually is 3 to 5 milligram per kilogram body weight. If the patient is 70 kilo, so he take 210 milligram in 2% xylocaine, which is common use. 1 ml contain 20 milligram, so the patient can take maximum 10 milli. If it is 1%, maximum is 20 milli. When the dose, if the gnocaine with adrenaline become higher, become 5 to 7 milligram per kilogram body weight. It is important to know that the contraindicated to give xylocaine or lignocaine with adrenaline in penis, so we don't do in circumcision, in ear and the nose, in finger and the toes, all these organ, it is contraindicated to give lignocaine with adrenaline. I show this a picture of the one have glands penis gangrene due to local xylocaine with adrenaline, which is contraindicated. It is important in any trauma patient to ask about tetanus prophylaxis. If the patient have tetanus prophylaxis in the last 5 years, you can give him booster dose. If more than 5 years, he don't take any prophylaxis, he must take anti-tetanic serum. This is dramatic appearance of the tetanus organism. Of course, don't forget to give a patient tetanus prophylaxis if needed, and according to if this patient is more than 5 years, so we give anti-tetanic serum. Less than that, we give toxoid. In this procedure, you start by introducing yourself. First thing missed by many students, test the sensation. So it is important by non-traumatic forceps. You can just test the sensation and ask the patient, you feel this or not? So the patient tell you, I don't feel. So it means that anesthesia is working. This is a step is missed by many students. After that, you need to prepare your instrument, choose the proper needle, proper suture, and do suture, and cut the thread, clean the wound, and cover the wound. Sometimes if you forget to do that, or you can just tell, I ask the nurse or assistant, you have assistant to clean the wound and cover the wound. Usually in the station, you have a big table like this, have a lot of suture. This suture is different needle. You have this tray, which is kidney dishes. You have the all instrument. So after you wear the glove, you pick toothed, non-toothed, non-toothed for skin, and the toothed to hold the needle, needle holder, scissor, put in this tray. After that, ask the assistant, I need this type of suture. Must be cutting suture, must be non-absorbable suture for the skin. So after that, you test the sensation. We mentioned that. Prepare your instrument. You take a proper needle, cutting needle, of course, and a non-absorbable suture. So you can use Purolene, you can use silk. Do the suture and cut the thread half centimeter, not too short, not too long. Clean the wound and cover the wound. This is the example, what is the interrupted suture look like. And you can see the distance between the first and second equal to the second and third, and the right side equal to the left side, and the knot in one direction. This is example of the bad technique, because the knots is in middle, must be right side and left side, and the student make it more tense. This is synthetic material, not a skin of human, but again, it is under tension, and the knot is in middle, must be right side or left side. Again, must be in this direction, right side or left side, and must be no much tension. Of course, I can describe the patient. I give you antibiotic. If it is lacerated wound or unclean wound, it's better to give him antibiotic. We give an instruction to the patient. This is an instruction that you remove the stitch after 7 days to 10 days. You can have some complication like wound infection or bleeding or fever. You can take a shower, but cover the wound with waterproof dressing. Of course, take a shower, be in a shower, so he don't able to go to swimming pool or to go to diving in the sea. And give him the contact number or how to contact the hospital. So again, the instruction of the patient to give him the where and when they remove the stitch, complication of the wound like wound infection, bleeding, and the pain, contact the number of emergency or surgical department, not your number. So this is the cut wound. Any comment from you? Any thing you need to ask? Just make a
على
suture.
tetanus vaccine.
Yes, a tetanus, it is, if it is less, if the patient say, I last time, it is more than 5 years, so give anti-tetanic serum. If it is less than that, you can give booster dose, especially in lacerated wound. So we have booster dose, we called it toxoid, and real dose, what we called it anti-tetanic serum. So it is important to give the patient or ask about tetanus prophylaxis. Don't forget that.
Okay.
Especially in lacerated wound or wound in the backyard or the garden or the field. After that, we have the second common station is excision of nevus. Excision of nevus, the same scenario, 20 years old woman in the day case for excision of the skin nevus under local anesthesia. So your consultant has prepared the skin, give local anesthesia, only to call to different theater for emergency operation. You begin ask to excise the lesion. So usually, of course, it is like a pad, so it is rubber pad, and they have this nevus is like mark by pen, and this is about less than 1 centimeter. So what you make first, of course, you prepare an instrument, and you wear the glove, and you test for sensation first. If the patient don't feel anything, you start to excise. Before or after, or before you excise, you just make an ellipse around it. This is ellipse. Usually you have either just to make it simple way, or just you can put, suppose this is 1 centimeter, so 1 centimeter above, 1 centimeter below, and about less than half centimeter or 4 milli or half a centimeter, 5 milli, just lateral, and make an ellipse. So again, this is the dose of xylocaine. They ask you about the dose of xylocaine. I don't repeat it. You choose after excision for suturing size either 2-0 or 3-0, and the needle is cutting and absorbable. You ask you need absorbable or non-absorbable. Usually, I use non-absorbable suture. It is again when you see the local anesthesia in both station, you can find first you're looking for expiry date, and if you don't remember the dose or you don't remember how much is written on the bottle, so is written here 200 milligram per 100 milli, so it's written in the bottle itself, and the expiry date is written here. So check the expiry date for suture, check the expiry date for xylocaine. Of course, we called it double check expired, meaning it's checked by 2 persons, but in the real time in the exam, it's difficult to have another person to check the expiry date. So just tell I have double check the expiry date, I have double check the expiry date of suture. So again, the dose, as you see here, the dose we needed is 210. Suppose it is 200 milligram, and is written in the bottle, if you forget it, that 200 milligram is equal 10 cc. So in the whatever the company, so usually they write the concentration on it. Of course, this is 2%. After excise, of course, you pick your instrument again. So you pick a needle holder, non-toothed, again, non-tooth for needle, and tooth forceps for the skin, and scissor. Of course, beside you, they have adhesive dressing to cover the wound. you have many suture, as we mentioned, so you select the suture, suitable suture. It is better to have it in cutting needle and either Prolene or Isilon.
دكتور معلش.
Yes.
Needle holder. Non-tooth forceps for needle. When you take it from the bucket ولا قصدك إيش؟
No, it is in the table. If you see in the table, if you see this table, so everything is put in the table. This is table supposed to be sterile because the patient in the bed here. So what you will do, you choose, you put in this tray, you open your suture, the assistant or examiner, another examiner opens the suture. So they put it here and you take everything and go to beside the patient, and suppose the area in the field of the patient is also, it is clean area or sterile area.
No, my question is if you use it non-tooth.
Yes, one toothed, one non-toothed.
Why you use non-tooth with this
Yes,
superficial
because
usage usually
because
non-tooth.
to hold the needle, it
Tooth.
is better to hold it by non-toothed, not toothed. You hold the toothed for the skin.
Okay, يعني once
So
you adjust the
non-toothed for
needle.
the needle and toothed for the skin of the patient, of course.
أنت قصدك بس when you adjust the needle with the needle holder. Because you will do the
But
skin
if
by
you need,
tooth.
yes, if you need to adjust the needle holder, suppose you have a needle here now. Suppose this is the needle holder, you have a needle. You need to adjust it. You don't allow to hold it by your hand. So you hold it by non-toothed forceps.
Okay.
Okay. So again, you can see this is a suture material. So you can found 2030. It is Vicryl, Rapido, or Vicryl. So you can found the detail. You can found expire date. You can found the type of suture. You can found cutting needle. So after that, you're looking, it is cutting or round. So we use cutting needle. And again, you hold the needle like this. So this is a needle holder, just looking to the outer third, and the thread is in the lateral, and you have two forceps, one toothed, one non-toothed. This is the high power of both toothed and non-toothed. Again, toothed for the needle and non-toothed for the needle and toothed for the skin of the patient. After that, you mark the incision first with the marker pen, usually available. So they have a marker and they make an ellipse. Remember to get adequate margins, like half centimeters is okay, not more because it's difficult to excise. Check the skin for anesthesia already done. Use toothed forceps or better non-toothed forceps. Excise the nevus. Put the exercise sample in a specimen in the container with label, confirm that it has a label, and ask to be sent to histopathology. It is important when you make the incision, I just enlarge this. So it is important to know because in the thigh, because we have in this is bad is put in the thigh, the line of Ringhahn in the thigh is a little oblique, but we prefer the longitudinal incision because we have a wrong picture from Wikipedia and it's distributed by many students that it is transverse incision. So the student insisted to make it transverse incision, which is wrong. So it is important to know that line of Langerhans in anatomy book is oblique and we prefer longitudinal incision, but we don't do transverse incision at all. Okay, after that, you have a container. This container have a patient name and the ID number, and you can check because the parcel attached to the patient. And after that, you cover and say, we send the specimen to lab for histopathology. And after that, you explain to the patient post-operative care is any complication like infection, discharge, fever. He come to hospital at any time, even in emergency room or department in the out of hour, and ask the patient here to come in outpatient clinic because this is maybe have a possibility to be melanoma or malignancy. So ask him after 10 days, you can come, or 2 weeks, you can come to have the result of histopathology and we can discuss the result together. Can be malignant, can ask about safety of margin or just a nevus. Okay? So this is about excision of the nevus. And again, when you excise the nevus, don't forget we have longitudinal incision. We don't do transverse incision. It is wrong, wrong, wrong. Okay. This is second. So any question till now?
No. بتدرى عند الفاي بس أظن.
Okay. After that, we have the wound debridement. It is the same. Also, we have bad, and this is rubber or whatever. In a patient 35 years old man have lacerated wound, again in the right side, because it is accessible in exam. You will ask to manage the wound. So, of course, the lacerated wound, you need to clean the wound by saline. You can put saline in syringe. You remove any hypercortical thickness of the skin, infection, foreign body, necrotic material, anything, you need to remove it. After that, you can find the wound. You need to trimming the edge. Of course, this simulated wound in the bed, in the rubber. So just trimming the edge, clean the edge, and just simple suture it. So the first clean, trimming the edge, suture the wound, cover the wound. And again, you need to ask about tetanus. A lacerated wound, the possibility of infection is high, so you must give the patient prophylaxis antibiotic.
دكتور معلش بس
Yes.
هذا مو station abscess.
Yes, we have abscess later. We
Why
come
you
to that.
close? Why you close?
Okay.
Why
After
you
that,
close?
say again.
Why you close abscess? كاتب suture the wound.
No, we don't close the abscess. I bring the abscess later, just again. We have also, we can also have deep knots. Deep knots, do deep knots. So that usually you have something like this. It is a container, can be plastic, can like plastic cup, but it is strong, and have a hook inside, and this hook, the base is magnetic. You can find in some simulation in the clinical skill unit. So if you make high pressure on the hook, so they come out. So the idea, don't make it come out. You must be steady. So we have this hook pad. So this is the deep wound. Do deep knots. Of course, use non-absorbable without needle. Use your hand or use needle holder, up to you. Don't forget to use your index finger to push the knot. So you make reef knots or circle knot and fix it one hand. So right hand here is fixed, and one finger, index finger, usually you push down to make it here. You can make it 1, 2, 3. Take care. This is detached and easy to come out with you. So it is better to use it with care. So again, in this station, you ask you to do 3 tasks. First, you make deep knots. Second, if you see this is 2 thread, he asks you can make a knot here, circle knot, just to make these 2 thread attached to each other or near each other. So the first task is deep knots by hook. Second is make these together attached to each other. After that, in the same station, we ask you if you have a bleeding point. So they have some bleeding point like this. We use the same pad here. I show you. So we make a like this and make like a dot, a small red dot. So this is dot, maybe the bleeding vessel, and you make what we called it H-shape suture. This H-shape suture is done by non-absorbable suture, and the needle must be non-traumatic, so it is a round needle. So in this station, we have H-shape or figure of 8 suture to secure blood vessels. We have deep knot. It is like mimic. You make a knot in the cystic artery or something deep, or cystic duct, and approximate the 2 line together. Okay, so they have 3 tasks in this station.
But you
and
use
this
round
station.
needle.
All without needle, except for H-shape, you use a round needle, non-traumatic round needle. Okay, but for this approximation, it is suture by silk usually, and it is without needle, and deep suture also without needle. Okay.
Need only silk. or you can use
Usually
Proline?
silk or borolene both can. What is available, you can use it. It's different from venue to venue, but what is both are the same. We ask you, it is just must choose something non-absorbable. Okay. And the good size, like zero, if you have zero, if you have something, is okay. It's better to be easy to handle. And again, don't forget to push by index finger. After that, we have abscess drainage. You ask about abscess drainage, and again, also the abscess in the right side. And again, these have longitudinal incision. So this is have this pad, and they put something like casters or toothpaste inside, and this is to mimic an bus in abscess. It is not a real bus, of course. So it's something like that. They put in the side of the patient, they wrap it. So what you need, you again, we supposed to give the patient local anesthesia. Also, it is not a good policy to give local anesthesia in abscess because of the pH of the abscess. But we mimic that because the next question usually they ask you about the dose of local anesthesia. So it is for the examination purpose. Of course, after that, after introduce yourself and consenting the patient, here you can looking for the consent. You can find this beside the patient, what we call the consent form. So we have a consent form and prepare your equipment. Don't forget here also you must have handle and the blade. Usually it is single-use handle and the blade. You prepare the skin or either the skin is well prepared and make the incision. It is important again to know in the thigh the incision is longitudinal. And some ask me about trimming of the edge. Trimming of the edge is not done in the thigh abscess. It is done in perianal abscess for different situations. So trimming the edge is done for perianal abscess, not in other abscess, and make it cruciate incision and make trimming of the edge. And usually we send it for histopathology because in England it is common if you have repeated perianal abscess or fistula can be one of the Crohn's disease. Of course, after you make the incision,
You not give
uh,
local anesthesia?
we don't give the local, is already given local. They already say we give the local is just in size. So you make the incision. When you make the incision, some pus come out. Of course, because before irrigation you take, they have something like the swab. You know, this swab used for ear. So they have something like a swab. So you can take a culture and sensitivity. So sample for culture and sensitivity is missed by many students. It is important to take in. After that, we can irrigate the cavity and dissect any loculi or any septum. Irrigation can be by syringe use saline or betadine or hydrogen peroxide, which is available. And after that, put a bag soaked with betadine. It is we show you this perianal abscess. In perianal abscess, we make a cruciate incision and we can trimming the edge. But we don't have an exam. In exam, we have just a simple abscess in the side. So if you have the abscess in the thigh, again, longitudinal incision, irrigation, swab for culture and sensitivity before irrigation, and we have pre-made very small, tiny gauze in a special bag just to open and either soaked with betadine or saline and put inside the wound, put a dressing, cover the wound, thank the patient, give him instruction. Okay, so for abscess, you have any question? You need to ask anything about abscess?
No.
Okay. After that, we have sometimes we have fine needle aspirated cytology. Of course, it is 35 years old woman complain of lump in right breast. Sometimes may be difficult to have a lady, so we make it like any swelling in the thigh, and we ask you again for fine needle aspirated cytology. Actually, this is swelling is usually we have something like cherry tomato. We put in the bed or something like any fruits like grape. So we have something tiny. Of course, we put it inside underneath this bed of tissue or bed of plastic and rubber. So, of course, you introduce yourself to the patient, explain to her the procedure. They can take verbal consent. We use 10 cc or 10 milli syringe with green needle. Green needle mean big needle. It is called the fine needle, but actually it is big needle. Big needle usually either green or gray, and 16 and 18. Introduce yourself, explain to the patient, verbal consent, use 10 milli syringe and green needle or big size needle. Although it is fine needle, but we use big size needle. Wear a glove, no need for local anesthesia. Some center put a local cream called the IMLA cream. Preparations of the skin by alcohol or betadine. Palpate the swelling. You hold the swelling by left hand. Insert the needle in and out in different time till you have enough tissue. Put the aspirate in 2 slides or more. And don't forget to write the patient name and ID or IC number. 1 slide, leave it dry, and second, spray with a fixed spray. So this is a needle. Of course, you choose the big size needle. Just remember green and gray. You hold the breast by left hand. You must have a gloves. This is wrong if you don't have a glove. They have a needle. They suck different time till you have enough tissue. Of course, we don't have a breast. We have this sample. So, or these fruits like grape or tomato. So you suck many times. You have just a tiny amount in this hump. And after that, you put in the slide. You can disconnect it and put in the slide. Don't forget, after you finish, you put everything used in the sharp, which is yellow bag. The same for suture, the same for all other stitch. So this is fine needle aspirated cytology. It is the same bed, the same tissue we use. Okay. After that, any question till now?
لا لا تمام. بس
After
سلايد
that,
واحدة سلايد ولا 2 slides؟
you mean no, it is 1 or 2, at least 2, because 1 we make it dry, 1 we put a spray on it. Of course, if you have enough tissue, you can make it 3 or 4. It is according to how many tissue you have. After that, we have male catheter, urinary catheter. Male is very common station. And of course, we use a mannequin like this. This is mannequin, although they have a reservoir, but we don't fill of water, so no urine is coming. So in the male catheter, introduce yourself, explain and consent to the patient. This is consent is verbal consent. Here we don't use written consent. We don't have what is called WHO checklist, which is for operation, is according the preparation of the skin and the fasting and all this. This is a procedure, not operation, so we don't have WHO score or WHO checklist. You prepare your equipment, which is a suitable size catheter, can be 16, can be 18, of course, full catheter. You have a kidney dish, you have gauze, you have syringe, 10 milli saline, you have lignocaine syringe pre-prepared, they have xylocaine 5%, you have urine bag, you have gloves, of course, and something to prepare the skin. So you start first by choose suitable catheter. You start to clean the area. You clean from one direction, either from penis to down or from down to penis to glands. And after that, the area in the front, you make it in circle manner and cover the area with a pad with a hole. After that, of course, you wear a glove. It is, don't forget, in some mannequins, we have retract the foreskin because some mannequin is not circumcised, so you need to retract the foreskin backward, and don't forget at the end of procedure, make it forward again. You hold the penis not by your hand, it is by piece of gauze, and put lignocaine or xylocaine gel inside. Okay, after you finish the xylocaine, you tell the examiner, I will wait for 5 minutes till it's working. He said, okay, 5 minutes is gone. After that, you start to introduce the catheter. This is introduce the catheter till the end. After that, of course, you need to be connected to the bag of urine. If no urine come, don't inflate the balloon. So we have two options here. Either the examiner say, suppose it is urine scum, so you inflate the balloon and fixes the tube and attach it to the side of the mannequin. If no urine come, So you tell, I don't insert the balloon, no urine come. I need to percuss the urinary bladder. I need to make irrigation of the catheter, maybe blocked by xylocaine or by gel. And I need also to do ultrasound in the urinary bladder or consult urologist. Okay. So this is tricky, but it is okay. So if no urine come, not inflate the balloon and ask for either irrigation or percuss the urinary bladder. Usually in exam, he said, okay, I give you the balloon. In this station of the catheter, usually we tell the patient, you are thirsty, you need to drink water. So it is better in this situation just to tell the examiner, would you please, I need a bottle of water, and the examiner give you water to give to the patient. Okay, this is just a clue. First, to see your communication skills, and also to put your mind, this patient may be dehydrated, and this is explain why this patient have no urine. And after that, he asked, what is the possibility if the patient have no urine? So you can write, it is maybe pre-renal cause, renal cause, post-renal cause. Post-renal cause, of course, the common here after insert the catheter is block the catheter by lubricant. Pre-renal, which is common, like because of dehydration, no enough fluid, and vomiting. Renal cause, of course, if the patient take nephrogenic drug or something like gentamicin or aminoglycoside. Very common station, very easy and simple. After that, don't forget, after you finish, or rubbish or glove, put in a special bag and clean the area and give any instruction to the patient and to record how many urine. So I need to record if come, how many urine is come from the catheter, just to know what is the residual urine. After that, they can calculate amount of urine every hour, which is equal half to 1 milligram per kilogram body weight per hour. Okay.
Okay.
After that, we have airway insertion. It is common in many country is airway insertion, insert airway in mannequin. We have two options here. We have laryngeal mask and we have endotracheal tube. So what happened? They give you scenario that we start by laryngeal mask. It is just a supraglottic airway device, temporarily misses to maintain open airway during administration of anesthesia. Our immediate life measure in some cases is difficult or fail airway management. So this is the laryngeal mask. Laryngeal mask is simple, and this is area is like a big balloon or oval balloon, and you can inflate it by syringe. To insert the laryngeal mask, this is the mannequin. Of course, the mannequin is fixed in this position, which is extension, which is the proper way to insert any airway device. And you can insert it in this direction. After that, you can rotate it and fix it to the oxygen. This is the endotracheal tube. If you ask you to insert the endotracheal tube, of course, you have laryngoscope, you have tube, you have syringe, and sometimes they have the airway. And of course, it is easy in the mannequin. Of course, you test the light before you insert. Before you insert also, you need to put the mask on the mannequin and make something what we called it pre-oxygenation. So we give a lot of oxygen to the mannequin just by mask. After that, I remove the oxygen and put the laryngoscope. The patient, of course, is extended position. We don't change the position. You put it, you found the light and inserted in the endotracheal, in the trachea. If you see this mannequin, if you see the mannequin before, this mannequin have something mimic down. If they have a lung, so you can find the lung is inflated. But you have something like a flat tube, like a stomach. So after you inserted, you have ambo bag. You can inflate the ambo bag. If you find the lung expanded, so it is okay. If you find the stomach, which is seen down, is expanded, just either remove it and try to put again. Don't worry, don't be in panic. Okay, so this man can have lung, have something like a stomach, and have both trachea and esophagus. And if you did it by mistake, you put in esophagus, just make it back and insert it again. Sometimes if you inflate it, you can find one lung is inflated, the second is not, just to make it little up, because maybe went to direct to the right lung and right bronchus, so it's better just make it up, that it easy. After that, we have a blaster. You can find in the table, of course, a syringe for balloon, and after that, you have a blaster to be fixed. Okay, this is many size of the tube. You can choose a small size to be easy for you, like 7 or 6.5. This is metal stellate in difficult intubation. Usually, we don't have difficult intubation in the exam. And this syringe, and this is tongue forceps. We called it McGill. If the patient have tongue affected your insertion or something, we don't use, but we have 2 mask oxygen before intubation to give the patient oxygen, and ambubac. Of course, after you insert it, you need to make a connection and connect it to the oxygen. Okay, so it is like a real patient. So you put a connection, you put everything, and it is easy and don't take a time. After that, we have that simple. If you mimic a trauma scenario, you ask you to evaluate the patient and put a cervical collar. So it is like 35 years old man, had a car accident in the highway, and he is a driver. So maybe don't wear the seat belt. So you are one of the ambulance crew looking for airway and cervical collar. So airway can be easy tested by asking the patient, he's speaking, airway is okay. But if the patient don't wear the seat belt, especially next to the passenger, you need to put this hard collar. To know the anterior from posterior, usually the anterior part is yellow in color. Not all collar have this opening. This is opening if you need to make tracheostomy. But all the collar nowadays have the yellow mark. Yellow mark means that it is the front. So the front is yellow. The back is the same, like the same color of this material, which is blue. So just easy. You can have different type, either we have a hole or no without a hole. Of course, to insert it, you need to hold the mannequin like this, and you need to hold it by your hand and the forearm. It is hold it like this. I just show you. So you can hold it like this. So you hold the head. So you support the head and the neck in one unit, and another assistant put the collar. Okay. The last task you can find in exam, it is come usually in England, is the chest drain or chest tube. Of course, insertion of chest tube, we have 2 options. The first, if the patient have tension pneumothorax, we insert the needle decompression in the 5th intercostal space, not the 2nd midclavicular, because since 2019, the ATLS version 10 changes the position of the needle decompression from the 2nd midclavicular to be the 5th intercostal space anterior to mid-axillary line. After that, we ask you, we have a mannequin like this. So this is a mannequin, and we have the tube, different size tube. We have arterial clamp. We have knife, needle. We have syringe for local anesthesia. We have suture for burst string. We have material to clean the skin, and we have some gauze and the plaster. So what you choose first is according. If this patient hemothorax, you need a big size tube. If the patient is pneumothorax, any tube after decompression by needle, any tube you can use. You can use the thin one for pneumothorax, but if you have hematoma for blood clot, you need big size. Usually the tubes come in the metal part. This metal part, we don't use it. This metal part to make the shape straight. So we don't use at all. It is just to make it straight for preservation. So you remove this metal part. Of course, you can start in this mannequin. Position of the patient usually is 45 degree. Is difficult to do in the exam, or the patient is leaning forward, but you need to expose this area, what is called safety triangle. So we expose the area, we explain to the patient, we have consenting the patient, and started by give local anesthesia. Before that, you need to count from the manubrium sterni to the second, third, fourth, fifth. So the fifth rib, so the intercostal space fifth is below the rib, not above the rib. So just below the rib or above the sixth rib, this is the fifth intercostal space. You give local anesthesia, and usually local anesthesia, you give it in the around the rib and sometimes in periosteum. And after that, by the knife, after, of course, you wait 5 minutes and just make a small snip by the knife. You can make 1 or 2, just less than 1 centimeter. So first is the skin. After that, by use of the arterial clamp, which one of these? By the arterial clamp, you separate the muscle. We have intercostal muscles, external, internal, innermost. After you separate the muscle, you can expose, you found the pleura. So after that, you need to insert your finger to confirm that you are inside the thoracic cavity. After that, you prepare the tube and put in the arterial clamp guided by your hand and push it. The direction of pressure must be up and superior, not lateral to avoid injury of the heart, not medial to avoid injury of the heart. So must be up, not down to avoid injury of spleen or liver. So must be up and laterally or towards the axilla to avoid injury of any vital organ. Of course, after fluid come out or blood come out, before that you are already connected to the underwater seal, which is a container and must be below the level of the patient. And you can find either blood is coming, so it is red in color, or air bubbling if the patient have already pneumothorax. After that, we can make a burst string. So the burst string using a suture, it is a cutting needle, usually it is silk 20, and make a circle around the hole, and after that fix it and put a plaster and put a dressing. Okay, so I just review the step. So the first step is inject local anesthesia. A small incision, usually insert above the rib, not below the rib, to avoid injury of the intercostal arteries. After that, you insert your finger to confirm that you are inside thoracic cavity. After that, you insert not insert your finger now. Insert a small incision first. Make separation for the muscle. After that, insert your finger. After that, insert the clamp and put the tube. So we start by local incision, separation by clamp. So insert the clamp first. After that, insert your finger and put a tube. So this is before that, just a minute. So we insert, put the clamp first. After that, you put your finger. Okay, because the clamp separate the muscle. Okay, intercostal muscle, of course. Okay, after that, okay, so this is insertion after you separate the muscle. After that, you put the tube. You must have a clamp here and the clamp down and connect it to the underwater seal. Okay, this is underwater seal and usually contains saline, not water. And again, the tube inserted in the fifth intercostal space anterior to mid-axillary line. Insertion or incision is make it just a small incision. You inject local, you make small incision, you insert the clamp to separate the muscle, you insert your finger, then insert the tube. Okay, of course, connected underwater seal and must be down below the level of the patient. Don't put it in the same level of the patient, and give the patient to clamp so during transportation or moving from any area, he can close it. Last station, which is so easy and usually can be part of the evaluation of the trauma, like ABC. So you can ask it by the airway. You can ask it to test the breathing and what happened if the patient have tension pneumothorax, and you put a needle in the fifth intercostal space, and you can looking for tracheal shift and hyper resonant on percussion and weak respiratory or no respiratory sound. After that is A, B, C. So looking for circulation, and they ask you to put a cannula. So it is just to put a cannula in the mannequin. This mannequin usually have something mimic blood, and just to connected fluid is better to give fluid rich of potassium like ringer lactate and connect it to the patient. So this is as a way of part of the insertion of the cannula in the mannequin. Usually in trauma, we have green or gray big size cannula. You can start by Hartmann solution or ringer lactate, and you just put the intravenous set, get rid from the air as usual, and after that, connect everything to the mannequin. Okay. So after that, of course, introduce yourself or ask the patient to confirm that airways is okay. Seek the patient identity, consent the patient, complication of intravenous line, maybe have extravasation or some little pain. Of course, you choose a big size cannula in trauma and prepare the fluid and flush the cannula. Okay, of course, it is important before you give the fluid, you need to check the expire date. In some center, usually we use expired material, but just tell it is already expired, but no problem because we don't use in human. And after that, prepare the bottle connected, get rid from the air. We have a special tourniquet. Don't use a glove. We just have a tourniquet, insert the cannula, apply the dressing. And usually when you put the sticker over the cannula, so they have a sticker, you put it and write the date of the insertion, because usually after 5 days, you need to change it because of the superficial thrombophlebitis. So we apply very thin sticky dressing and write the date of insertion of the cannula. Okay, so that's it as regard the all procedure skill come in your exam. Okay, all right.